A couple of weeks ago, I was blessed with the task of speaking at AIUM. It's my first time there, had an amazing time, got to learn from some amazing individuals. I learned that Corbin Haycock, who is like the critical care echo guru, he lives near me. I'm in California now and he's in California, so it's pretty sweet. I'm hoping we can collaborate a little bit more in the future. I actually recorded this lecture at the conference, so live. I was ready to go, but I had, unfortunately, the thing that I prepare for all the time, mentally, it hasn't really happened before, but the projector stopped working, right? Which is kind of a bummer, but I continued the talk. But the issue is that it wasn't a good recording because I didn't have the slides with it. At least I don't think it was very good. Took me a couple of weeks to be able to sit down and record this here in my home office, and I'm very happy to actually do so now. So with a little bit of delay to those people that I said I'd send out the lecture basically the next week, I'm going to talk about assessing fluid responsiveness in the critically ill patient. Check it out.
If you're not good enough at ultrasound, that's not an excuse to punish your patients with radiation.
Get out there, ultrasound some hearts, some lungs, some IVCs. Let us know how you feel about it.
Yeah, we can definitely do that, or we could be better clinicians and use our ultrasound.
Let's start off with the definition of volume responsiveness. So volume responsiveness is defined as a 15% increase of the cardiac output with a bolus. And that can happen with an actual bolus. That can happen with a passive leg raise, which is an interesting thing. Now, I want to kind of condense this a little bit because this could be a whole conference in of itself. These are things that I am not going to talk about. I'm not going to talk about, do you even need to use volume responsiveness? Because if you're here, I'm assuming you already kind of are interested with it and you just kind of want to know how to do it. So I'm not going to talk about its utility. I'm not going to talk about this controversy because there is a big controversy. Some people love it, some people hate it. I'm in the middle. I use it when I think it's appropriate and I'm not always using it, and I know the limitations. And we obviously are not going to talk about the non-POCUS assessment. I'm also not going to talk about Vexus. I'm not going to talk about the right heart because all of these things were actually discussed by other people at that course. So we're going to keep the content a little more condensed as far as what we are talking about today. So this was fun for me. I hadn't done any kind of a volume responsiveness talk in a few years. So I spent weeks looking up on PubMed, which I love looking up primary literature on PubMed. I love it. But I looked it up and I did a bunch of different search methods to find stuff. And I found that there was actually quite a bit of methods available to assess volume responsiveness in critically ill patients. It's kind of an intimidating list when you first look at it. Whenever I see a list like this, that's a little bit on the intimidating side. What I do is I try to break it down and see what some common themes are. So there's basically two different ways that you can look at it. The first one is this way. If you look at it, there are really 4 different methods. Even though you're looking at different organs, there are 4 different methods you can use, and that's the VTI, the change or the delta in peak velocity. You can look at the carotid flow time, or the, corrected flow time, and then you can also look at the percent change of a chamber. When we look at this, there is this list, and this actually, I had some help with this. I emailed Rory Spiegel, I showed Felipe Rolla, I showed a bunch of these critical care docs, Taryn Trott, a bunch of these critical care docs that I know for help on how to make this a little more palatable. So there are situations in which certain tests are going to be more useful, and this is a chart that you're more than welcome to take a picture, a screenshot of, and use however you want, right? This is all for education, it's all free. One of the ones that are important is the fact that the ideal patient for volume responsiveness is somebody who is mechanically ventilated and not breathing over the vent. Their tidal volume is greater than 8, and they don't have an arrhythmia. That's the perfect patient, that's what you want. But there are some situations in which you can use volume responsiveness measures on patients that are spontaneously breathing, that even have an arrhythmia. The VTI is actually one that talks about that it can be used in arrhythmia. You just have to take 5 measurements and average them. So it becomes a little more cumbersome, but you can use it. And the reason why, by the way, is because if you have somebody with an arrhythmia, they're obviously, they're not gonna have a consistent kind of flow going to wherever you're looking, carotid, jugular, the heart. And so that's why you have to average it, right? Because they assume you take the average of 5. That's probably the right answer somewhere there. What I like is percent change, and specifically with the IVC. This one's actually been shown to be useful in patients with arrhythmias, which is actually pretty sweet. Now, I know IVC is a bit controversial. I'm going to talk about why I think it's okay to use in certain situations. The other way that you can categorize these and look at them is not necessarily by the method in which you are evaluating. You can also talk about it as far as just the organs that you can look at. So we have the carotid artery, the brachial artery, the IVC, the IJ. Yes, the IJ. It's old school, right? You know, we looked at the length of the IJ in heart failure patients. Like that is, you can look at that with ultrasound. It's crazy. And then probably the most studied one, the ones that we're most comfortable with, is going to be looking at that LVOT. Now with these, it's not fair, but I feel like the harder it gets to actually get a good view of it and to actually use it, the more evidence there is. And then the ones that should be really easy and are actually really easy are the ones that there's actually a little bit less evidence. So it kind of stinks, but this is what it is. Let's talk about VTI, probably the more common one. Now with a VTI, this is velocity time integral. It's like some math stuff that honestly, like I will be honest with you, I struggle with, like, because I didn't actually take calculus. I somehow got into medical school, only having taken a little bit of trigonometry. I took trig-based physics, got good enough to trick somebody into letting me go to med school. I'm very happy about that. But in any case, this is some kind of calculus stuff. And what you're really doing is you're trying to measure the amount of blood that goes through a certain area over a heartbeat, over a period of time, right? And most commonly we think about this as far as the LVOT outflow, and we think about how much blood is actually going through that LVOT. And there's a lot of different calculations that you can do. You can actually take this VTI, you can take the diameter of the LVOT, and you can take the heart rate, and you can actually calculate cardiac output. So this is just a component. But you can use it in volume responsiveness because of a bunch of different things. The most important one is that the LVOT diameter doesn't really change at all, even if you're severely volume depleted or if you're completely volume overloaded. So that's why you can use just the VTI specifically for the LVOT. And like I said, this is the most common one, and this is how we usually get this image here. And I'm going to talk about these a little more in depth, but this is just what it looks like. We're just looking for the envelope of the flow going through the LVOT on an apical 5-chamber view to get that number. We can also look at the change in the peak velocity of blood flow. This one's probably more studied with the carotid artery. This is what we're seeing here, but there is some evidence with the brachial artery as well. And the reason I like this one is because when you look at the literature as far as volume responsiveness, one of the gold standards is actually looking at the changes in peak velocity on a radial art line. So you're basically doing that, but with ultrasound and not having to actually cannulate the artery. So I think it works pretty sweet. The next one that I'm going to talk about is the corrected flow time. This is something that when I first heard about this, years ago, I was so excited because one of the problems with looking at Doppler ultrasound, which all of these except for percent change, which IVC and the IJ, all of these actually require you to use pulsed wave Doppler. And if you don't have your angle right, your pulsed wave Doppler measurement might not show the appropriate amplitude. Corrected flow time gets around all that. You can have the complete wrong amplitude. You can be at almost 90 degrees, your pulse wave Doppler gate with flow, almost 90 degrees. And as long as you can tell when systole is and when the rest of the cardiac cycle is, you're golden. So you just basically take the measurement between the beginning of this first spike to the end of this dicrotic notch right here, that's systole, and then you do some math with some square root stuff over the entire cardiac cycle, and you get a corrected flow time, most studied with the carotid artery. I think most of us are probably familiar with the IVC. It's something that, I learned very early on. And I also learned that, don't use it. It's horrible, which I think it's actually pretty useful, and a lot of the critical care doctors that I talk to these days actually use it. I mean, you got to know when to use it. It's just knowing which tool to use in which situation, right? But it is useful. With the IJ, this is another one that I was actually surprised that there was some literature to back this up. It's kind of cool because we really discussed not using M mode when you're measuring the IVC, and I'll talk about why. But with the IJ, they actually measure it in cross section, which is cool, in M mode, so you can easily see what the collapses are. I think it really makes the measurement pretty easy. All right, now that you've had an introduction on how this all works, let's talk about exactly how to perform this examination. Let's start off with getting your LVOT VTI. To get this view, you're going to want to get your best apical 5-chamber view. So what you do is you get an apical 4 and you're going to tilt your transducer ever so slightly down towards the feet, and you're going to get this 5th chamber, which is the LVOT. That's this right here. Here is the aortic valve. And when you get this view of the aortic valve, what you're going to do is you're going to place your pulse wave Doppler gate right on the inside of that LVOT, just on the ventricular side of that aortic valve, and you're gonna get a measurement, and this is what it looks like. So there I got my pulse wave Doppler. I'm going down, placing it just proximal to the aortic valve, hit that PW button again, and I'm gonna get this waveform right here. This is I'll have to say, a pretty decent waveform right here. And we know it's a decent waveform because we have a hollow envelope. Hollow envelope means that you're in the middle of flow. So you're having a good job at getting the flow exactly at the location in which you want to get it. And a lot of machines have auto calculators. So you just basically put 1 bar there and 1 bar on the other side. Like I'm going to show you right here. This is an auto tracing on this specific machine. And boom, you have your VTI. You can also do manual tracing as well. There's other devices that have manual tracing. There's other devices that actually have full auto VTI, like you just do an apical 5-chamber view and then just automatically calculates it for you without you having to press any buttons, which is really cool. But if a machine has the ability to do VTI, it's usually going to be this way. Either you manually trace it or you're going to put it at the beginning and the end of that hump of the flow through that LVOT to get that VTI. Now, this actually takes a bit of kind of finesse. It's not like you take one number and then you're good. What you want to do is you get that first VTI and then you either do a passive leg raise or give them a bolus. So the passive leg raise is an auto bolus of 200 to 300 cc's. It's in their spinal circulation, it's in their legs. It goes into the chest. And that's good because if you have a patient in which if you gave them too much volume, they actually would do worse. They start to get pulmonary congestion and all this stuff. You just put their legs down and it'll redistribute. So it's no harm done, no harm, no foul. Or you can just give a small bolus, which is honestly what I'm normally doing. Get that VTI, do passive leg raise or a bolus, and then you do the VTI again. If the second VTI shows an increase in the amount going through there by about 12 to 15%, depending on what source you look at, that patient is considered volume responsive. So you give them another bolus, see how they do. And then you repeat the same thing, so on and so forth, until the patient stops increasing their VTI. So it's a bit complex, but that's how you use it. Now I'm going to talk about one that I'm a little more excited about lately because it makes sense to me and it seems fairly easy, and that is the change or delta in the peak velocity. So it's basically to see over a patient's just normal respiratory cycle, and this is most studied in the mechanically ventilated patient, just to see between the different kind of pressures in the thorax what the maximal and minimal velocities are. So to get this view, what you're going to do is you're going to get a carotid view. What I usually do is I usually get it in the short axis to try to find it. And then as soon as I found it, then I'll turn it into that long axis. And you want to measure it about 1 to 2 centimeters from the bulb, which is this guy right here. You see it's a little bit bigger right there. That's right where the common carotid splits off into the internal and external carotid. Place your pulse wave Doppler on there and you're going to get these spikes. And the way that you measure changes in peak velocity is you find your peak and you find your trough of the maximal velocities, and then you figure out what the change is. And if that change is greater than 8 to 14%, and that's just patient breathing, you don't have to do any intervention to get the change, the patient is considered volume responsive, and you just basically give fluids until that number goes below 8 to 14. And by the way, there's a range because studies can't seem to agree on exactly what that number is. And that's one of the problems, by the way, with volume responsiveness, is that there's really no like cutoff number that this always means the patient's volume responsive. So, it's always like a range with the clinical situations, how you kind of determine it. The other organ that we can look at is at the LVOT. What's really interesting here is that there's a few studies, I quoted one right here, where they actually mention doing this, the LVOT. You know how we got the VTI earlier with the LVOT, but this is actually looking at just the peak velocity. So it's actually a much easier measurement, I think. And some machines, some packages of ultrasound machines don't have the VTI. So this would be sweet. It's actually not studied in adults. It's studied in kids. And there is also this like super broad number with kids, but it's an option. It's something that you can do in the right clinical setting. The next one I want to talk about is corrected flow time. So this is a basically identical view for what you did for the peak, the change in the peak systolic velocity with the carotid, but you are doing something slightly different. So instead of measuring the different peaks and seeing what the difference is, what you're doing is you are actually measuring the time in systole over the time of the entire cardiac cycle. So to get this, what you're going to do is you're going to measure the beginning of systole, so a big spike right there, to the dicrotic notch. So that's going to be systole time. And then from here to here is just the cycle time. So you take the systole time here over the square root of the entire cycle time, and that'll give you a corrected flow time. Now the data here, I mean, it's insane because it should be awesome. Like it should be like, oh my gosh, it's amazing. We don't have to worry about Doppler angle, but the data is not great. And the numbers are all over the place as far as when you determine if your patient is volume responsive or not. So there's one study that talks about if it increases by 7 milliseconds between boluses, they're fluid responsive. That's systole time basically. If you have a greater than 5 to 25% change with fluid, that's like a thing. And there's other studies actually give a cutoff number, which is kind of nice. Less than 345 to 349 milliseconds is considered volume responsive, because presumably if you have more volume, you're going to have more time in systole. That's why it's a number below that. But this is crazy, right? I mean, what if you were just like a little off, like a little tick mark off? It might be the difference between 360 milliseconds and 340 milliseconds, right? So using this, I'm excited to learn a little bit more about it, but I feel like the data here is honestly probably one of the more weaker data points, but it is there and it is something that you can use in the right clinical setting. Now, before I leave this section, we have to discuss the Doppler angle a little more in depth. So there's 3 different tests so far I've mentioned that use Doppler. So it's the flow time, so the corrected flow time. Then there's changes in the peak velocity, and then the VTI. Those all use that pulse wave Doppler. Now, as I mentioned, if you're just looking at corrected flow time, the Doppler angle itself doesn't matter. As long as you can tell where systole starts and where the entire cycle is, that's all you need. But you have to make sure that when you are looking at the peak velocity or change in peak velocity and the VTI, that you are less than 60 degrees. So your Doppler line and the gate needs to be less than 60 degrees with the angle of flow. And that's really going to dramatically change it. And I didn't really appreciate this so much until I saw this article that was made by our friends local here in California, where I live. Actually, it's a funny story. Alan Chem, he was a fellow when I was a medical student. So I was like a medical student under him when I did my rotation with Chris Fox at UCI. It's pretty sweet. I just like love that we still like talk and we're still friends and I'm still seeing him publish stuff. It's all great. In any case, this was a great study right here. So what they did is they took 51 patients that had different insonation angles used. These are just patients in the ER, not necessarily needing volume responsiveness. They're just patients. And they looked at the different angles. So they compared 3 different numbers of angles, 46, 60 degrees, and 90 degrees pre and post a passive leg raise. And this is crazy. So let's look at 46 and 60. We have this mean change in the peak systolic velocity, about the same, standard error about the same. So this is good, right? But when we get closer to 90, look at this difference right here. 9% to 18% change. And these are the same patients like right after each other. And this shows you that you can get a incorrect change in the peak velocities if your angle is greater than 60. You have much more deviations with what you'll get just based off the angle. Now, I'm sure somebody that's super smart will be able to say exactly why that happens. I don't know. I'm just going to assume it's like magic and that's just how it works. So all that to say, less than 60 on your Doppler angle is very important for everything but corrected flow time. Now, let's move on to the IVC. I think this is one of the ones that could be easier to get as long as your patient isn't like fluffy. They don't have a bunch of like bowel gas or something kind of getting in the way of that IVC. The way you get this is you use a phased array or a curvilinear transducer. You place it in the subcostal window, probe marker facing up if you're in a non-cardiology setting, or probe marker facing down if you're in a cardiology setting. And what you're doing is you're observing the IVC as it moves through a respiration. And what you want to do is you want to find the maximal diameter by the minimal diameter and actually use that to figure out percent change to guide fluid management. Now, a couple of things on how to identify the IVC, because it actually happens. The IVC and the aorta, sometimes you can get kind of confused about what they are. In textbooks, traditionally, the IVC itself is thin-walled, it's non-pulsatile, and not muscular. But, I mean, the IVC sits right next to the aorta, and I often see pulsatility with that IVC, and sometimes the walls, I don't know what a thick wall is for this patient, but maybe they have some vascular disease, and the walls are a little bit thicker. So usually the way that I differentiate them is, first off, I place it in cross-section first, in transverse, and just look, the one on the left is the aorta on a normal, non-transposition of the arteries or whatever, non-situs inversus patient. The IVC is going to be on the right and the aorta is going to be on the left. But the other thing you can do in the long axis is look at the IVC and the vessel that's going straight, like almost like horizontal, right into the right atrium with a little hepatic vein going into it. This is the IVC. And if you have another vessel that goes behind the heart, that is going to be the aorta. So that's one of the ways I differentiate. I don't ever want to see this, ladies and gentlemen. I never want to see anybody measuring the IVC on M mode. It's just ridiculous to do this. A lot of studies, like I'm reading these articles and I'm seeing that they're using M mode, and respectfully, this is not the right way to measure. And the reason for that is the IVC itself can move in the cranial-caudal direction pretty significantly, actually. Let's look at this clip right here. So this is an M mode cursor showing the corresponding M mode image above. And you can see here that when I take a big breath, I go from measuring the appropriate location on the IVC, which is about 2 centimeters from the right atrial junction, to measuring the right atrium. That's how much the diaphragm can move stuff. So if you use M mode and you look for a percent change, you're measuring 2 completely different areas on the IVC, maybe even the right atrium. And so you're not actually getting a good measurement because you got to compare apples to apples. You can't compare apples to oranges. So what I usually do is I will actually have the patient go through a few respiratory cycles, and I then hit freeze and I will like cycle back on the machine, find the diameter as the patient took that big breath in, and then mark it about 2 centimeters from the right atrial junction, which would be about right here, measure the diameter, and then have the patient basically breathe out or cycle back on your machine until the diaphragm is the highest, and then measure that exact same location on the IVC as your other diameter. Sometimes you don't really need to do any kind of calculations. I mean, let's look at this guy. It's tiny, it's compressing 100%. This IVC is small, and this patient likely won't be harmed by fluids, might even benefit from fluids. We look at this guy right here, and it's just really plump. It's dilated. As the patient breathes, we are having no changes in the diameter at all. This patient likely is not volume responsive, right? Because it's big. We don't have to do any measurements of it. But if you want to get an exact number, the number is, it's all over the place. It's all over the place. And that's one of the problems with IVC, is that the data is good, but oftentimes you can't use one study and add it to another study because they use different cutoffs and sometimes even different calculations to measure it, which it's really frustrating actually. Now, as I mentioned, there are a lot of different calculations even that people use, but this is the way that I use it. And I like this because this takes into account the difference between a distensibility index when a patient is mechanically ventilated versus a collapsibility index when a patient is spontaneously breathing, because the mechanics of how pressure changes in the chest are different if you're getting breaths versus you're doing your own breaths. But this is what I use: maximum minus minimum over the maximum times 100. If we look at the literature, there are a lot of studies out there. There's 4 meta-analyses that I was able to find that actually talked about this. And some of them even separated out with the number in which somebody would be considered volume responsive or not versus vented versus not vented. But let's look at the broad range here. Let's look at that third study. The one in Critical Care 2018 included 6 studies. Vented, so these are mechanically ventilated patients, the number varied between 8 and 21%. It's a huge, broad range. It's kind of crazy. But it did show a great odds ratio for predicting volume responsiveness, 9.28. Now, if we look at all these other odd ratios, all these other sensitivities, they're not like amazing, right? They're not like 100% sensitive, or 100% specific, but the numbers are decent, right? If you don't have anything else at bedside, you don't have one of those fancy, bioimpedance devices, you don't have somebody that has a Swan-Ganz in or a radial R line that's able to measure this, these are a good, easy, and non-invasive way of being able to correlate the collapse with their ability to tolerate fluids. And even to maybe increase that cardiac output of fluids. So this study was pretty cool. So one of the things that I mentioned earlier is that the best patient is somebody that's greater than 8 mLs per kg as far as tidal volume. But a lot of our patients are not. We have to put them on lower tidal volume. So this study actually looked and found that in patients that had, just like a meta-analysis, less than 8 mLs per kg or greater than 5 of PEEP, so I guess that's like the alternative, low tidal volume, you add PEEP, the numbers, while less, were still somewhat useful. So it does show that you definitely want your patient to be at a higher tidal volume, but if not, there is still some potential values with it. We have a diagnostic odds ratio of 4, which if that's all the data you have, you're golden, you're good. These are my personal numbers. So if they're spontaneously breathing, I'm looking for a greater than 40 or 50% change. And if they're mechanically ventilated, I'm looking for a 14 to 18% change. This is just my interpretation of literature, because otherwise it'd be like way too broad and like intimidating to use. So take this with a grain of salt, but these are the numbers that I look for. I want to end with probably like the most exciting one for me, just because like I never like thought that it was like a thing necessarily. And that is looking at the collapse of the IJ to assess for volume responsiveness. So this is going to be in a similar location to where you do the carotid artery assessment for peak flow, as change in peak flow, as well as for the corrected flow time. It's going to be a little lower though. So there's some studies that the majority of them, there's not like a lot of studies by the way, but the majority of the studies, they say to look at the cricoid cartilage and go just lateral to that cricoid cartilage. One of them actually says to go 2 centimeters from the clavicle. Place it in cross section. That's right. Cross section, transverse, and then stick that M mode cursor in there and just see what that collapsibility is with your M mode. This is, I don't know, it's pretty cool stuff. The IJ apparently doesn't move in a craniocaudal direction like the IVC does, which makes sense. When we breathe, we're not like lifting our head up off our necks, So the IJ doesn't move, so the cross section works really well here. And there's not a lot of data, but this is the data that we have out there. We have one study that looked at spontaneously breathing patients. Thank you so much for that, whoever published that study. And it showed that greater than a 36% change was associated with volume responsiveness. And then if you have a mechanically ventilated patient, greater than 11 to 18% change was associated with volume responsiveness. Now, this is like a lot of stuff to go through, so I came up with this. I got my evidence up here on the top left if you happen to want to look it up, because I'm a very evidence-based guy. These are the numbers. Again, feel free to take a screenshot of this and use it. That's literally why it's there. Now, as far as me, my go-tos, if they are vented, I'm going to go for the LVOT VTI, because I think that one is probably the most studied and the one that most people are familiar with, just make sure that you understand what's going on with your Doppler angle. Just make sure that you understand that you have to try as much as possible to get the exact same view, to get the exact same Doppler angle every subsequent time that you're measuring this. Because remember, if your Doppler angle and your second measurement is off by a couple degrees, it's going to seem like the patient's going to be volume responsive, right? Because just the swing, you might be perfectly on flow for one of the flow through the LVOT, and then a little off, and that will actually give you a big swing in the VTI. So just be careful with that. And then if patients are not ventilated, I usually use the IVC. Now, we're going to talk about a very important concept. And I don't spend too much time on this because in the initial AIUM talk, it wasn't like part of it necessarily, but I had to mention it. And it's a concept of volume tolerance. Now, I think this was first brought up by Lichtenstein a few years ago, and then Scott on his website, MCRIT, started talking about it a lot more. Scott and others, of course. And I like this concept. It's a volume tolerance. And it's the idea of, instead of thinking, will fluids increase my patient's cardiac output, volume tolerance asks the question, if I give patient fluids, will I harm them? Which I think is like a pretty good kind of silver medal way of figuring out the volume status of your patient. The way that I look for volume tolerance is if I have a patient that's gotten a bunch of fluids, which by the way, I'm not really even asking this question unless I'm like, I don't know, 4 to 6 liters in on most patients. If they have heart failure, they're on dialysis, I'm going to ask this question a bit earlier. But what I do is I look at the IVC and I look at the lungs. And I ask myself, do I feel like this patient is volume overloaded or not? Or not. And I do that by looking at these two things. So we have a lung view on the left. We're seeing a lot of B lines, which remember B lines mean an increase in density. And in this situation, it'd be fluid. And then on the right side of the screen, we have an IVC that is very plump. It's very dilated. It's not collapsing with respirations. If I see this on a patient that's hypotensive, I'm unlikely to give a large amount of fluids because there's a chance that the patient won't tolerate those fluids very well. Whereas if I see this, a bunch of A lines on the left and a very flat IVC on the right, I'm much more likely to give that patient fluids, assuming that the fluids are not going to harm them. And I think both things, volume responsiveness and volume tolerance, are both two things that are important and should be discussed. But the point of this was definitely volume responsiveness. This was a very fun lecture for me to give. I learned so much doing the background, the research for this, and I'm using it. I don't use it on every single one of my patients, but I do use it in the appropriate patient. Just like I don't use my saw to hammer a nail. I use my hammer for that. I don't use volume responsiveness when it's not clinically indicated. That's it for this week's ultrasound podcast on core ultrasound. Don't forget to check out our courses page. That's courses.coreultrasound.com. We have recorded conferences where we have a bunch of educators from all over the globe giving us their advice, their input on what they think is important. And we also offer the Core Ultrasound Fundamentals course as well as the Core Ultrasound Question Bank. And this is something that's geared more towards residencies. We have assessment questions. It's 3,200 pathology questions where you just look at them and you say, hey, is this right heart strain or not? We're not going to put a complicated clinical scenario behind it because you're all medical providers. That's not the information that we hope to give to you. We hope to give to you the image recognition kind of part of it where you're seeing a lot of normals, but mostly pathologies and knowing that is right heart strain or that is an effusion. And then you take that knowledge and you take it to the bedside to figure out what to do with that patient. So check both of those things out on courses.coreultrasound.com. Hope to hear from you soon and happy scanning.
If you're not good enough at ultrasound, that's not an excuse to punish your patients with radiation.
Get out there, ultrasound some hearts, some lungs, some IVCs. Let us know how you feel about it.
Yeah, we can definitely do that, or we could be better clinicians and use our ultrasound.